simple situation, the ASD closure. Unfortunately, not all ASDs can be closed, and some are more difficult, some easier. What is going to be the definition of difficult ASDs is, well, if you cannot close it properly, it is difficult ASD. I mean, I think it's worthwhile giving some observations and some tips and tricks in some situation where technical can be difficult. Well, some words about the complications, how to treat and how to avoid first, and some consideration about the ASD that cannot be closed. Just a few words. Of course, we have to identify correctly the morphology, the size of the ASD and the morphology, the atrial dimensions, which is going to be compatible with the device we are going to put in. Consistency of deficient rims is a peculiar and important detail to be taken into account, and of course the deficient or absent rims. Well, this is an example of a simple transthoracic echo in a large ASD with almost non-existent inferior or caval rim with just 2 or 3 millimeters, very floppy rims. This is a patient that I will send to surgery directly. There is no way to put the device there large enough to achieve a stable position with such anatomy. That's another example with deficient inferior or caval rim. I think this is, in my opinion, the real only absolute contraindication to put the device in the atrial septum, large ASD with deficient inferior caval rim. Well, just very, very briefly, the step-by-step we follow in the cath lab assessment of the ASD by 2D, 3D echo. That's a small ASD with very nice definite rims. We don't need to do an angiogram just to see in this particular case the good correlation between the fluoroscopy and the echo. Well, that's the issue of sizing, balloon sizing. Somebody does in 100% of cases, somebody never does. Well, we routinely do balloon sizing in spite of the fact that in such a defect with relatively small hole with really definite rims, the balloon sizing will give exactly the same dimensions without doing the size. It's more important to do a balloon sizing, in my opinion, when you have a floppy rims, actually. Then we deploy the left disc. We go ahead and deploy the right disc. It's very important to see on both echo and fluoroscopy the correct position of the device. I'd like to see on both echo, of course, and fluoro as well, the 2 discs parallel to each other and the true distance between the 2 discs, even when doing the push and pull or Minnesota wiggle or whatever you call it. If you are happy with the position, of course, we release the device. By all means, I rely more on echo appearance more than fluoroscopy, but both are useful in setting this stuff. Of course, angiography is not necessary, but it's nice to see in this left anterior oblique view with cranial angulation how the device is pinching the atrial septum with the 2 parallel discs. This is another example of very large ASD, however, with good rims. And as well, this is a good defect that can be closed rather easily with a single large device. Well, that's the issue of deficient anterior ring, which is in fact very, very common. At least more than 70% of the patient has a deficient aortic rim. It's not considered an absolute contraindication, but it's technically more demanding. And we need some tricks during implantation. And as we said in the previous discussions, it is considered at high risk for erosion. Well, the technical problem that we face usually, very often during device implantation in deficient anterior rim is that the device is popping through the defect. That's an example with the deficient aortic ring, where the device is deployed into the left atrium. When approaching the atrial septum, actually it's slipping through the defect. So we have to use some tricks to avoid this problem. One of these tricks is to open in the left atrial disc or in the right upper pulmonary vein. We saw an example during live transmission. This is usually okay, but there are also other possibilities. I don't want to mention all, but there are many actually. For example, they use two catheters, deploy the left disc in the left atrium, and with the second catheter pushing the left disc and keeping it in place. The same stuff is used, a modification of this technique, just to use the stiff wire with the 1 centimeter soft tip. This is the soft tip, which is in contact with the left disc, keeping the device in place, and then the device is released, and avoiding the slipping through the defect. This is the final angiogram showing the good position of this device. Another possibility is the balloon-assisted device. This is slipping through another venous access. We inflate the balloon, inflating the left atrium, holding the left disc in place while deploying the right disc, and eventually achieving a good position of the device. So there are several tricks. Just to finish up, the use of pre-shaped sheath, the Hausdorf sheath with a double curve, or there are also available on the market now some steerable sheath that can be useful to avoid the slipping the device through the defect. So there are several possibilities to avoid these technical complications. So virtually in almost all patients with deficient anterior rim, provided that the defect is not huge, we can put the device successfully. Well, some years ago, we reviewed our experience from 2000-2007 of more than 1,300 consecutive patients with ASD referred to our institution, and with no selection, no previous selection. So elective surgery was performed in 3.4% of the cases. Device was attempted to implant but not released because could not achieve proper position, 2.2%. Device embolization occurred in 0.6%, but you see successful percutaneous closure was achieved almost to 94% of the cases is consecutive non-selective secundum ASD. That's another possibility, morphological variations of atrial septal defect with a multiperforated septum. That's an example of a rather floppy septum with multiple fenestrations. We can appreciate the anatomy even better by 3D reconstruction of that. In these particular occasions, we do not attempt to do a balloon sizing because we do not want to size anything. We want to avoid to stretching the septum and transforming a multifenestrated defect in a huge ASD. So we try to enter the left atrium through the most central portion, I would say, which is a bit arbitrarily defined. And the device that we want to use in this particular case is not an unplugged ASD occluder, but a cribriform device with different size depending upon the length of the septum, etc. This is an example, an angiographic example of another case of multifenestrated defect where a cribriform device was used, a test angiogram before releasing the device. Well, you see in the levo phase, the left disc is well positioned, so we can release the device, and that's it. Well, there are some other occasions. You can call it large ASD, multiple defect. You see a lot of jets across. Sometimes it's not easy to distinguish between two holes and just a single hole with just strands of tissue in between. In this particular case, the balloon sizing is probably helpful, and in an anatomy like this, a single large ASD occluder is the right device to be used. You see the good position after release. Well, that's another example of a aneurysmal atrial septum, as you call it, with a very, very floppy septum with multiple jets across it. Well, as well, in this particular case, you can decide to use a very large cribriform device. However, you may take into account as well the inconsistency of the rims. So in this particular case, a single large atrial septal defect occluder, traditional ASD occluder, was chosen, and it was successful because the tissue of this aneurysmal septum is so flimsy, so floppy, that it equal as a large single ASD. If you look at our experience during that years of all multifenestrated ASDs, you see that almost 78 to 80% of these defects could be closed in the cath lab. Well, multiple ASDs is a rather different situation, as shown in this transesophageal echo of this patient, where you can see very nicely two jets across the atrial septum with a fairly distance between the two holes. In this particular case, there is no way to close these defects with a single device. So we have to use a simultaneous implantation of two devices, which is quite feasible, as you see here. And in this particular case, I think it's very important to do a balloon sizing or balloon interrogation, just to test whether there are the size of the holes, and in addition, where there are additional holes as well or not. And that's the echo appearance after implantation of these two devices. Well, another example of a double ASD with two sizing balloons inflated across the two holes. And in this particular case as well, you are going to use two devices. And my attitude is to deploy the smaller device first and the larger later on, because the larger device is going to embrace at least partially the smaller device. And this is the two devices partially overlapping on this patient. Also, for multiple ASDs, we could close more than 80% of consecutive patients in the cath lab without sending to surgery. Well, there are some occasions where you come across, well, unusual situation. This is a patient with dextrocardia, of course, so a cardiac malposition, but you see there is an additional problem. That's an azygos continuation of IVC. So there is no way to enter the right atrium through the left atrium through the right atrium, because this tortuous course to the azygos vein is going to be impossible. So in this particular case, the solution was to get the access to the left atrium through the jugular vein. It was actually rather easy to get into the defect, deploy the device in the mirror image heart, the test angiogram here, and that was an unusual situation we can come across. Well, when you have an azygos continuation or to some extent difficult access to the ordinary route, you can consider the transhepatic approach as well. Well, if you look at our experience, consecutive patients from 2000 to 2011, or almost 1,800 patients with secundum ASD, you see along the years from 2000 to 2012, more than 80% of patients were corrected in the cath lab, avoiding surgery. Well, complication. Of course, we can have complication, but probably I don't want to spend a lot of words about that, because Tarek is going to cover this specific topic extensively. You can avoid AR embolism, thromboembolism, arrhythmias, and device embolization as well. I just show you an example. You can embolize on the right side, but also on the left side. So that's an AUS occluder in the aortic arch. Well, first of all, no panic. Do not rush to do something because you can make additional mistakes and make the situation even worse. So you have to think and plan what to do. What to do is theoretically very simple. You have to grab the device properly in the pin attachment with the snare. That's the usual way to go. And I would suggest to get a larger device in the groin and larger introducer in order to achieve a device extraction as smooth as possible. But it is also, well, it's possible to retrieve virtually all devices from everywhere. Well, it would be better to avoid embolization, of course. But if it occurs, again, don't panic, just think about that, because most of the times there is no hemodynamic compromise of an hemodynamic of an embolized device. So you have time to think about what to do. So another trick, when you have some doubts about device stability, this is not a huge defect, but moderate size with a very floppy septum. It's rather difficult to anticipate whether this floppy septum will hold the device in place, yes? So the solution or the trick we are using is to snare the device with the gooseneck advanced over the delivery cable. So when you release the device, if you're not happy, you still have the device attached to a gooseneck snare and you can retrieve it. On the other side, if you are happy with this, you just release the gooseneck and you achieve the final result. So that's a trick that has been useful in some cases in our experience. Erosions, Tarek will talk about this problem and other complications, and I thank you very much for your attention.